Welcome to CGR and happy Independence Day again to all. So this is the first CGR from Trauma Emergency Department. So we thought of giving an overview about emergency department, our trauma and emergency department. What is the current status, how it's began, and historical perspective. What are the future goals, and what are the current trends in India and other countries. So we start with the case vignette. This is very common scenario we come across nowadays, like a 20-year-old male patient having chest pain on left side, which is radiating to the left shoulder and arm, and he's also having associated palpitation and sweating. And post-COVID, we have seen and also heard the news about this young patient getting this kind of symptoms. So consider being a patient, or if one of the family members or one of us suffers this kind of symptoms, so where we would like to bring this patient to. So obviously, so there could be options. Patient directly think about going to cardiologist, CT surgeon, emergency department, or a casualty department. So we'll discuss what difference between emergency department versus casualties. And before going to a hospital, there are so many things comes to your mind. How will be the department? How confident you going to utilize our emergency department as well? So to think about that, those perspective as well. How confident in your services? How will you think that your patient or your relative will be taken care of, and how whether they will be able to manage those kind of common emergencies in timely manner or not. So any patient has a right for this all terminology mentioned here. So in 2001, the Institute of Medicine has mentioned these 5 or 6 parameters for improving the quality of patient care. And they mentioned every patient has a right of safe and effective care. Patient-centered care should be there. It should be timely, efficient, and equitable. And so in the emergency department or setting of emergencies, the safe, effective, and timely, they are become more utmost important, along with patient-centered and equitable as well. So whenever we think about patient care, we have to think about these different domains and where to provide such care. So what is emergency medicine? Is it new to India? So few years back, when we used to discuss with among our colleagues and we used to say we are from emergency medicine, they used to frown their eyes and ask, is it separate branch? Is it new branch? So emergency medicine is a specialty of medicine which manage urgent and life-threatening medical and surgical conditions. It mostly deals with rapid evaluation and treatment of diverse patient population in a single roof and under single door. The skills which required of the person who are attending the emergencies, they should have special knowledge in all emergencies, skills and specialized procedures in life-saving procedures, and should be equipped with all resources to provide timely and effective care for this critically and injured patient. Definitely in India, the emergency is evolving field. In last 10 to 12 years, it is evolving and rapidly gaining momentum to improve the patient care in acute settings. So we can summarize the emergency is jack of all trades and master of time, because timely we have to manage the patient, otherwise we'll lose the patient. So what was the need? So most of us who are sitting here, when we did our residencies, we did not have this emergency medicine, but still the patient were able to manage. So I'll just brief again. So this is the first CGR of emergency department. So as it was first, so we thought of as a team discussing about giving an overview of emergency department to the institute as well as the young medicos or young undergraduate postgraduates to give the overview of this emergency department, what is about and what are the scopes of emergency medicine in India. So you just start the case scenario like a 20-year-old guy developing a chest pain, radiating to the left side with palpitation and sweating. So very common scenario we come across post-COVID as well. And when these settings or symptoms comes to mind, or any of our relative or we if developing such symptoms, so things start coming mind, where should we go? Where should we go so that we can be timely taken care of? And we also always think how efficient or how care will be taken in our settings as well. So common scenarios in a layman will think about going to cardiologist, no settings, CTVS, or emergency settings, or any casualty. We will discuss how the casualty differs from emergency medicine department, but these things often comes in mind. So in Institute of Medicine 2001 has laid down these different domains in which a patient has the right to get care, which is safe, effective, patient-centered, timely, efficient, and equitable. And more so often in emergency setting, it should be more of safe, should be timely, and should be efficient, along with patient-centered and equitable. So, as you mentioned, Department of Emergency is it native to India? So when we did our residencies, this terminology was not existing. And few years back, when we used to discuss with our colleagues regarding emergency department, they used to frown their eyes and asked, okay, is it really separate entity? So over past 10 to 12 years, the emergency medicine is rapidly evolving, and it mostly deals and specializes in managing urgent and life-threatening medical surgical conditions under single roof. It involves rapid evolution and treatment of patients which are diversified and coming with the different issues. The person who on the floor should be able to manage and should have specialized knowledge and skills to understand those problems, and should be acted in time so that it covers and manage the patient within a limited time frame, so that he can improve the diagnosis, morbidity and mortality of the patient. And definitely it is still evolving. We can't say it is existing, but yes, over 12 years the rapid evolution has been seen, and it is a lot of scope in future. So as an emergency physician, we can say, so they are jack of all trades and master of time, or master of resuscitation. So what is the need? Few years back was not there, so how is going to make a difference? So we can see we have a large population. The number of cases or number of mortalities we can see, because most caused by cardiovascular diseases, followed by infections and trauma, which require urgent attentions. The number of persons with devices, in view of increasing the specialized care, increasing ICU care, these persons are increasing, so they often get complication and frequently they visit to emergency department. Patient post-transplants are increasing, so they also develop severe acute complications. We need to be timely managed. And overall, the pre-hospital care, the time when the symptom starts and the patient reaches to the hospital, that care between this window period is very suboptimal in our settings. So it emphasizes on developing such a care so that we can timely manage a patient who is still arriving in the emergency. So we discussed the health system, how it evolved. So this is just map of diagram of a tertiary care center. So we can see the patient's entry points are usually two, one OPD side and emergency. And after coming to OPD or emergency, patient will be diversified either to IPD, if a patient is stabilized. Patients who are sick go to ICU. Those who are surgical needs go to operation theater. And those are otherwise stable, come for some minor procedure, may go to daycare settings. But unfortunately, over the time when the system has developed, the more emphasis was given on OPD settings, IPD, ICU, and operation theaters. But somehow the emergency was not given such importance. Maybe due to it required high resources and high manpower, and it usually happens the things which require high resources may be neglected most of the time. But over the time we have recognized and timely, now we have started the department in our country and try to improve the care of the patients. So usually the disease process or acute injuries start here, and patient need to come to emergency using these pre-hospital services, which are, as mentioned, are suboptimal, and till the time they reaches, they already have lost their golden hours. So which we always mention, the golden hour, if we give timely care, then patient outcome definitely going to improve. But unfortunately, in our settings, till the time they have come, they already have lost this golden hours. And if you see the emergency data, the average duration of stay in any emergency will be around 6 to 8 hours. Before they can be stabilized, they can get definitive care, or the beds can be available. Patient spend most for initially important 6 to 8 hours in emergency. So if you don't have prompt care in emergency, the golden period or silver period is already lost. And many patients who need acute care may be getting more complications. More often so, the emergency department used to manage by the residents, neighbor residents, that we used to say that get more training, more exposed to sick patients. But this is like a diffusing a bomb. So a patient who is critically sick, if he asks a neighbor patient, a neighbor resident to just go and diffuse this bomb, so either he's going to explode, but luckily this patient explosion will not happen on doctors, but definitely a family member will be suffered if this patient is not managed timely. If see our data also, like mentioned our pre-hospital care, so these were one of the data from our resident, this is from our resident. She has done the impact of pre-hospital care on patient coming with severe injuries into our hospital. And we can see the kind of pre-hospital care and the mode of transport most used by most patients are either their personal vehicles, so 70%, 83% in different kind of injuries, and as well as the pre-hospital care received before coming to any hospital was very minimal. So we can see in these settings also there is more urgent need of the emergency medicine. So this was a document released by Niti Aayog in 2021, and this was a national level assessment of emergency services at secondary and tertiary level. And AIIMS Jodhpur are also part of this assessment of Rajasthan state. And in this document, they have mentioned the preparedness of emergency services are very suboptimal throughout the countries, and they have emphasized on strengthening structural emergency infrastructure, and which can be done by starting academic emergency departments in various institutes. So how it is different? So usually in this, previously the emergencies are managed by individual departments in silos. The coordination are there, but the ownership of the patient or ownership of the department is lacking most of the time. So it is also known as the man of no, emergency is also known as a man of no lands. So somebody is needed who can take the ownership and start stabilizing the patient in the golden hour. So it includes the care of all patients without under knowing the specialty, whether surgical or medical or injuries. So it deals with all emergencies, cardiac, neurological, renal, GI, psychiatric, toxicological, surgical specialties, as well as trauma emergencies. Available 24/7. The care differs, like should be fast paced, team oriented, and should be faculty driven rather than resident driven, so that the urgent decisions which can not be taken by resident can be taken by the faculty immediately, and the patient can be saved timely. And the most important is the dynamicity of and diversity of the patients which are received in the department. So we just have a look of the historical aspect. So how the concept of emergency medicine is developed over the years. So if you see the history, the documentation of some emergency procedures or the saving of life in acute settings are mentioned since 700 before BC, but the actually emergency department or the need of emergency are more also needed or understand in the era of world wars. So when there was number of patients with injuries were increasing, and the acute care was lacking for those patients, and there are more of deaths happening in the war area. So they recognized those things, and they thought of giving care at the same place. So treat them where they lie. This was mentioned in the 1861, the war which happened, and the ambulance trains was recognized. So in 1796, during the Napoleon's invasion of Italy, the Dominic Jean Laire the first time used the ambulances or the carts driven by the horses to fastly transport the patient from the acutely injured side to the other sides. So that's why the Dominic Jean Laire is also known as the father of emergency medical services, which has thought of those transport services. In 1962, Harry Platt had understood that, because initially there was terminology used was casualty, which was more related to the injuries. And he understood the fact that it is not only for surgical emergencies or trauma emergencies, it includes medical emergencies also. So he first time ennoted the term accident and emergency services, which include all kind of emergencies in coming to the hospitals. If we talk about the modern era, how the science has developed, so it was 1967 where the Casualty Surgeon Association was founded by the Maurice Ellis in UK, and in the 1970 first time the University of Cincinnati launched the first emergency resident physician program in the world. So it was way back around 40-50 years back when the first emergency program was started. In 1971, the University of Southern California established Department of Emergency Medicine, the academic department, and finally in 1979, the American Board of Medical Specialty recognized emergency medicine as a recognized separate medical specialty. So if we see about the different countries, how it has evolved, so you can see in US, it was recognized in 1968 and especially recognized in 1979. And so among the same period, within 10 to 20 years, the Australia, UK, Canada, they have already specially recognition, but it was still lacking in India in that period of time. So over the period, the emergency medicine, the American Board of Emergency Medicine recognized different subspecialties, and they certified other subspecialty under this umbrella of emergency medicine, which include the toxicology, pain medicine, sports medicine, the brain addiction medicine, and especially related to pediatric emergency medicine. So within 2 years of recognition of emergency medicine, they recognize the children are not small adults and they require special care. So in 1981, the pediatric emergency medicine was developed as a special department. So if we come to our country, so how is the emergency medicine developed over the time? So it was in 1994 where CMC Vellore has started the first ED in the country and to have formal accident and emergency department. Along with in private setting, the Sundaram Foundation has an emergency department in private setup with the overseas help. Then a society of emergency medicine, SEMI, was formed in 1999 and they hosted first kind of emergency medicine congress, that is MCON in Hyderabad. Then there was one more society, that is Indo-US collaboration was found, and Academic College of Emergency Experts were founded by AIMS Delhi and the experts from US, and they organized first INDOSEM Congress in Delhi, and they published a landmark white paper on requirement of academic emergency medicine in India, and they have defined the structures and the processes and the importance of that, and they have done various efforts to make the policy changes, and it was in 2009 after that efforts the AIM was recognized as a separate specialty by MCI and National Board, and after that the separate emergency medicine department was started. Before that there was a few diploma courses and master in emergency medicine course was used to be done, but the formal academic emergency medicine department was established after 2009. And in NMC, after recognizing the importance of emergency medicine, it has made a mandatory to start all medical colleges to have a separate academic department by the year of 2023. So if you see the graph here, so after around 30 years, we are able to recognize as a separate specialty, but we can understand India is in most need of such a specialty because of poor pre-hospital care and very large burden of population and large burden of patient in the emergency settings. So how the different stages of development of emergency medicine in different countries used to be there. So they are defined 3 stages: underdeveloped, developing stage and developing stage. So mostly it is based on the attending doctor who is first handling or supervising the emergencies, who is looking after emergency overall and about the kind of pre-hospital care patient is receiving. So we can see in underdeveloped stage, the house staff and non-emergency physician used to take care of emergency services. Non-emergency physician is director of emergency services, and the pre-hospital care usually taken by the private cars and taxis. And over the year, you can see in developed stage, it is the emergency residents who are managing emergencies supervised by the emergency physicians. Emergency physician is looking after overall, and the pre-hospital care is provided by paramedic and physician are by the advanced ambulances. So if we can see where we stand, so we are improving on this stage, but still our pre-hospital care lying here. So we are moving from underdeveloped stage to developing stage, and a long way to go to have this stage still in our country. So we see after the NMC has mandatory made the EM departments, so it is on 2023 data from NMC website. So total number of colleges which have now recognized emergency medicine have accepted it, 151, and total seats which was filled during this counseling was 486 for emergency medicine. And you can see the most highest seats are in the southern part of the India, and Tamil Nadu is having the highest seats for emergency medicine in India. So we look at the overall structure. So this was one of the map from established emergency from US. So our structure is also similar. So they have a separate entry for patients which are coming by walking. Those patients who are brought by ambulance have a separate entry, that is ambulance base, which is near to the red area, that is critical area. And it is have nearby services like radiological and blood banks and other services, so that patient need not be to transfer to the other required services very often. And they have a very fast track where patient is who are not very critical ill but definitely require a fast pace of management. So nearby they have fast track areas. And in view of increasing psychiatric emergencies, they have a separate chain for behavioral or psychiatric emergencies as well. So this is the overall structure. We also have a similar structure in which we have our radiology services and diagnostics and blood bank were nearby to the hospital. A separate work of ambulance and walking entrance is there. So how does the patient flow occurs in emergency? So as soon as patient is coming to emergency, so it will be triaged by a trained staff or a resident. So triaging is a process which is very hard to the emergency and basics, very important step for patient coming to ER. So triage is basically sorting out or segregating patient into different categorization, whether patient is sick or very sick or not sick. And different triage protocols are available in country or in various country use their own triage scales. So there is a Manchester triage scale, Canadian triage scale, Australian triage scale, and in our country the AIMS Delhi has released recently 2 years back AIMS triage protocol. And for children there is an emergency treatment and triage protocol available, which we are using it our center. So these different triage scales divide the patients on acuities, maybe in the 5 to different stage, or maybe in 3 different stages like sick, non-sick, and mildly sick, or you can say red, yellow, or green. So these patients, once approach to emergency, has to be triaged, because if we don't have this process in place, all patients will come to the management areas, and it will lead to overcrowding and lead to disturbance in the management or engagement in the management of other patients. So emergency, the principle mostly happen that it is for the care of a sick patients. So the patient who are non-sick should be segregated from the sick patient, and among sick they are more again classified between red and yellow. So who are acutely sick, they should be on the resusc beds, and who are going to be sick are having a probability of going to be deteriorated, they can be in the yellow triage. And it is more of a dynamic process, so it should be continuous. A patient who been yellow can be sick anytime, so he should be shifted to red. So it's not like that once you categorize the patient which remain into same category always. So you have to, it is a dynamically you have to always monitor and shift them. So once patient is stabilized, he may be the subspecialty department can be called, and the patient can be shifted for definite care. Patient is stabilized, it can be shifted to ward. If patient is sick, patient shifted to ICU, or if requires surgical emergencies or trauma, if requires surgical, then immediately can be shifted to OR from there. And here the lot of things, processes happens simultaneously, like patient shifted to radiology services, coming back, discharging from here, going to ward. So it's very high turnover site where the lot of process going simultaneously. So chance of errors, chance of medical errors will be higher in such settings. This was the AIMS protocol, which divide usually patient into red, yellow, and green area based on their airway ABCD status, as well as their vitals, as well as based on the mechanism of injury. So this is a basic armamentarium point of care test, point of care devices which are required for management of sick patients, like resusc beds which are equipped with high-end monitors, ventilators, and good teamwork. Equipped crash cart with all size equipments, even taking care of the pediatric patient, dedicated ECG machine, blood gas, point of care ultrasound, which has been now very useful tool in emergency settings, which help in understanding the dynamics of the patient, a hematanalyzer to give quick reports, and bedside X-ray machines. So these are the point of care tests which are needed for managing a sick patient. And when patient is stabilized, then depends on the need, patient may shift to radio services, imaging for CT, MRI, and maybe OR area. If you look at the advanced armamentarium, a patient may require hybrid OT. These are the advanced devices, ECPR, that is ECMO CPR. So patients who are acutely sick, not assisted by the usual resuscitation, and they're salvageable. So emergency the ECMO can be started even in emergency service, emergency settings itself. Cath lab should be nearby so that a patient who are having cardiac emergencies can be shifted if required. These are the recent devices like Riboa and the IABP, which are required in patients who are having either trauma or having very poor cardiac contractility, so that can be resuscitated with these devices. Obviously, the emergencies it's not a single man work; it requires teamwork, which include importantly trained nursing officers, trained residents, and monitored by the trained faculty members, and good support by radiodynamic services and lab support. And we are blessed with those in our setup as well. So we are very this all facilities available, which is very nearer to the emergency services. A good backup by blood bank 24/7 for patient with trauma or other things which require blood transfusions. A good ICU backup so that patient once stabilized can be shifted to ICU. Otherwise, if you don't have the ICU backup, there will be lot of clogging in the emergency department. Surgical, medical, and other specialties once patient get stabilized, so that can be taken over by the other departments. So other than these routine emergencies, so we often come across these disasters or mass casualty incidents. So disaster is defined when the number of patients exceeds the number of capacity available in the hospital. So we have few incidents of disaster and mass casualties in the past, and for that managing we should have a surge capacity so that we have extra resources to manage such incidents. Should have disaster protocol in the plan, and as well as in rare incidents like CBR and emergencies, triaging should be there, like for chemical, burn and radiation, nuclear and emergencies. So having mentioned about the processes and the services required, so how should we evaluate the quality of care given to emergencies? So quality of care can be assessed by various different modes. Either you can assess the capacity, how well equipped emergency is there to handle the emergencies, like for ED beds, ICU beds, physician staffing, or from the temporal aspect of the patient coming to the emergencies, like high acuity, how many patients of high acuity or low acuity you have, how are the admission of the emergency department, like length of stay overall, or how much duration is taking and the patient for discharging from the emergency, time to triage, like patient once entering the emergency, how much time staff is taking to triaging the patient, time to start of treatment, time to ED bed, and time to treatment condition. So these are the all time dependent parameters which gives insight into the quality of care being given to the emergency department. Other parameters like quality of the health workers, outcomes, and financial expenditure, especially for corporate settings. These are different model of 4-hour standards in which input, throughput, and output can be understood, and these different standards can be measured for quality of care. Like again, same total time in the ED, total time in the ED less than 6 hours for 100% of patient, total time in the ED for less than 8 hours 100%. So this tells us how well equipped we are and how we'll equity with managing the patient in the ER. This is one of the Donabedian model of quality of care, which is very well used in assessing the services of healthcare system. So it basically seeing the three processes like structure of the overall structure of the health system, processes as well as the outcome. So based on this structure, process and outcome also we can evaluate the quality of standard of the emergency services. So like initially we have mentioned this domain: safety, patient centered, timely, efficient and equitable. So we can divide them into structure, process and outcome, and we can monitor those different things into account. So many times the questions comes, so what is different between emergency medicine and critical care? Are they same or are they different? So more of this, it is continuum of care. Once patient comes to emergency care, they stabilize and go to critical care. And without critical care, emergency services will be clogged and there will be very high load on the emergency services. So a good critical care backup is needed for a good emergency services. Though settings are slightly different, like the pre-hospital care is a part of EM, mass casualty incidents, disaster management more often in the emergency department. patients, we don't have a control, so we can't stop the incoming. In emergency settings, while the critical care, we can have that. It's more of uncontrolled department compared to emergency department, but more so often it is a more of continuous care of the patient in the hospital service. So, having understood by the various terminology in emergency department and the flow process, now I would like to invite Dr. Amit to describe the trauma of emergency department at AIMS Jodhpur. So, we'll tell about how it is evolved, what is the current data about the emergency department in our institute.
Good morning, sir. I will start with how the Department of Trauma and Emergency started at AIMS Jodhpur. So it started back in 2017, and the first batch of the academic residents joined in 2020. Then right now currently there are total of 12 academic residents, junior residents are being trained, and the first batch has recently cleared their MD exams. So talking about the patient load at emergency AIMS Jodhpur, it is an ever increasing patient load we are witnessing since in past few years. At the initial stages in 2018, there were 17,704 patients in a year. Now this number has risen up to 36,000 in last year 2022, and till now in half of the year till June we already had 23,000, so this is going to be projected somewhere around 45,000 this year. So the patient load is continuously increasing year by year in the emergency department. This is regarding how we are handling the cardiac and the cerebrovascular emergencies. So in the beginning 2019, in the whole year only 11 thrombolysis were done for ST elevation myocardial infarctions patients, and with the help of involvement of the stroke team for acute cerebrovascular accidents, 17 thrombolysis were completed. Now this number has gone up to 258 thrombolysis for ST segment elevation myocardial infarctions in 2022 and 66 thrombolysis for acute cerebrovascular accidents. So we are witnessing that there is a rising trend in these kind of emergencies presenting to the emergency department, and as well as the interventions we are doing in the emergencies. So this is a trend of triaging, how we are triaging the medical and the surgical emergencies. These are the total number of the patients coming to the emergency department with medical emergencies, somewhere near about 2,000 to 2,500 per month, and how we are triaging it in the green triaging, in the yellow triage, and in the red triage. And similarly, we have this data of the surgical emergency, trauma and surgical emergencies. So we can see that green triaging is slightly less, which ideally should be more. Green triaging should be more, so that depends on how effectively we are screening the patient at the screening desk, and how effectively we can able to strengthen the green triage area. We can hold the patients there and treat at there itself, so that the patient load and burden in the emergency can be decreased. These are some admission rates for the patients who required the ICU care. This is the data of the 2023 from January. So in January, around 350 patients presented to emergency who required ICU admissions, out of which nearly half of the patients, around 180 patients we could admit, and others nearly 130 patients we have to refer. So every month this data is going like same only. Nearly 40% patients, even after doing complete management, managing the patient, handling the emergencies, but because of the non-availability, we have to refer these patients to other hospitals. And this is the average time duration if we talk. So in the red area, in the red triage patients, the average time of duration of stay in the emergency department is around 6 hours, with the minimum time of 15 hours and maximum time of 10 hours. So sometimes this is also a problem for us because of the patient clogging. We cannot send the patient, refer the patient somewhere else because of the patient condition. We cannot admit the patient. So many a time it happens that patients need to have to stay in the emergency itself. So these are those critical patients. Many of these patients are on ventilator. So we have to manage these kinds of patients for even for 8 to 10 hours in the emergency department. So this is for the pediatric data. I would like to call Dr. Bharat sir.
So thank you, Dr. Amit. So we are managing pediatric patients also in a single roof. So we can see the over the time the number of patients is increasing. Until the mid July, we are close to the 5,000 patient, and we expect to have more than 10,000 patients this year. And these are the triage, and we can see the emergency priority and queue triaging of the pediatric patient, and we can see the almost 50% patient who are coming to ER are sick. They have priority or emergency triaging in pediatric category. So there are various admission rates for PICU and NICU, and these are referral rate for pediatric patient coming to ER, which varies from 3 to 4%, and the admission rate to PICU varies from around 6 to 8%. So what are the challenges overall as an emergency department in country? We have like suboptimal pre-hospital care, which is very important in the management of the patient. If patient doesn't receive a good optimal care in pre-hospital settings, so definitely till he reaches to the hospital, the condition of the patient deteriorates and the outcome definitely will not be good. So suboptimal pre-hospital care is definitely not good for patients in emergency. Overcrowding is the story of all emergency in country. Lack of trained manpower, as emergency evolving over the time. Now only it is 10 years as a subspecialty, so it will take time to have a sufficient number of emergency physician in the country. Lack of networking among various hospital. So once patient is coming to us or any hospital and it gets overcrowded, so we don't know what is happening in other hospitals. So it is also part of the pre-hospital care and the networking. So we can't divert the ambulances, or we cannot divert the patient to the other hospital knowing what is his current status. And most of the condition, all hospitals are getting busy in our setting because of the number of patient load each and every hospital has. Obviously, the high risk of the job, and it leads to burnout in the physician. ER physician is more common, and like in other settings, ICUs, OR settings, the burnouts are common issues in established emergency departments. And as a first contact person in the hospital setting, other than the OPDs, so physical violence are also common because of overcrowding and communication issues. So the person who are working in emergencies are more exposed to such issues. So what issues particularly we are facing? As at present, we have only 12 beds, and the number of patients, as Dr. Amit has mentioned, are comparatively high as we can take care of in current strength of bed. So sometimes there will be no passage from coming from one place to other place. Trained manpower, so nursing officers, trained residents, we have 12 residents till now, and the faculty members, so need more emergency trained faculty members in the department. And as the number of patients are more, so disposition after circulation will be difficult many times, and we have very high referral rates. So as a tertiary care center and referral centers, it feels bad to refer patient from here, but unfortunately due to the resources available, we have to refer patient after as there are no beds for the patient in the emergency or ICU. As the crowding is a issue in all emergencies, and how it can impact the care of the patient, care of the person who is delivering the care. So it can have impact on the patients. So lot of patients get accommodated, the patient who are in high acuity or sickness. So definitely there will be delay in assessment, increased walkouts, and due to the medical errors can be increased in such settings. Healthcare delivery system process can be affected due to high workload, and definitely affect the quality of care which a patient should receive. Is definitely affected by the high crowd in the emergency departments. So how we can deal with this high crowd, or how we can dispose the patient fast, or how we can make system changes so that still in the available resources we can manage those patients. So in 2023, American Pediatrics has released this document that challenges and best practice for the care of children in crowded emergency department. So we can divide the emergency into input, throughput, and output. So in input, as we don't have much control, we can't refuse any patient to come to emergency. But definitely from other areas, like from OPD, other areas, we can avoid refer to patient to the emergencies which don't have any urgency, so minor procedures or non-emergency procedures, so that input we can reduce at our settings. Those sick patients who are coming to ER, we cannot refuse or we cannot control them. But among our systems, we can refine the patients being referred to the emergency. Throughput. So once patient is arrived, we should have timely triage, immediate diagnostic evaluation in a department, and boarding of the inpatient should be immediately. But as mentioned, we have at least 6 to 8 hours, 8 to 10 hours of duration of stay in the emergency. So if we have rapid availability of reports in the ER, so it will take 4 to 6 hours to get the reports from lab reports, because already there is a overload there. But if we get immediate reports, the fast decision can be made for patient treatment, and they can be disposed very early. And like the dengue season is coming, every patient will end up in emergency. They require a CBC to get decision for their fluids and other disposal. So if we get faster report, or we can have point of care test in emergency like CBC immunizer or KFT report, point of care machine in the ED itself. So the fast disposal can be done, and this can also lead to decrease in the ED overcrowding. And through output, so many patient lives without complete treatment because of the overcrowding. Patient disposition may be affected by the ICU settings. So we can have more good protocols to shift the patient to ICU timely. And if we be informed, like ER team can be informed how many beds are available from the hospital administration in the morning itself. So we are prepared how many patient we can take in the morning itself and timely refer the patient after stabilizing those possible. So through input, throughput, and output, we can have some system changes, and we can still decrease the overcrowding in our settings. So what is the overall manpower required? So we can see the various data from the various different developed countries. Like UK have currently 6,600 EM physicians for covering a population of 66 million. USA around 50,000 EM physicians are working to take care of 25 million of population. In Singapore, there is one emergency medicine per 10,000 population. But as per data, for covering 1.4 billion population, we need around 1,40,000 EM physician for emergency care. And the amount of seats we have, like 146 or 160, so it will take 140 years to have such number of emergency physician in the future. So there's large gap in the manpower, and the requirement is there still. So coming to the young guy, our undergraduates, when they think of taking this specialty, whether they should take or not. So the quality which required by residents, so they should have a behavior which has accept of challenges, like they should have sound and quick decision making, a frontline assist to directly encounter the patient, having interest in seeing the diversity of patient, so they can see surgical to medical or trauma patients together in ER itself, a good communication skills, and they should be more resilient. And the pros for this also, once patient get stabilized and improved, so you get a lot of reward by yourself that patient is getting improved by your interventions timely, and you can save so many lives. So if the undergraduates who are listening this CGR have these qualities, they are welcome on the board. So coming to the case which started, so I'd like to Dr. Amit again to discuss the management of this patient briefly.
Thank you, sir. So coming back to the case at the start of the CGR. So this is a real case. A 28-year-old male patient presented to the emergency department with a history of acute chest pain since last 2 hours. And as soon as he entered the emergency department, he suddenly developed cardiac arrest. So after attaching with the defibrillator, the monitor was showing ventricular fibrillation as the initial rhythm. So immediately he was acted upon by the efficient team of emergency medicine residents and the staff. It took 15 minutes of the CPR, 3 DC shocks, and the patient was finally revived. So after the patient achieved return of spontaneous circulation, we took a 12-lead ECG, and the ECG was showing ST segment elevations. So at this point of time, we thrombolized the patient, and because of the low GCS post CPR, we have to intubate the patient. The patient remained in the emergency for 4 hours, and by the time he regained the consciousness, and in the emergency itself, we extubated the patient. And after that, we shifted the patient to the cardiac ICU and patient underwent angioplasty. And finally, the patient was discharged with full GCS. So what I think went right here with this patient is a proper triaging. If this patient would have been somewhere else in that Bay Area or in the yellow area, and if he would have not been triaged properly, then it would have been difficult to save the patient. He was in the red area because he has a history of acute typical chest pain of a cardiac origin. He was triaged to red category and he was immediately attended by the emergency residents. And after that, the patient was taken up by the cardiology team, and then the patient was discharged with the full GCS. So here, not only a young life is saved, a whole family is saved. So this is about the case. Now I would like to call Bharat sir.
There are a lot of things has been said, but to be done in the future as well to strengthen services further. And it's a lot of responsibilities on the ED department for current strengthening of services, improving the pre-hospital care, training of the paramedics, training more and more lay persons and bystander to give the immediate care of the patients who are witnessing the cardiac arrest or any witnessing any trauma by the side, having innovation in the point of care test and resuscitation medicine, and developing more and more emergency specialty like toxicology and other psychiatric emergencies and other emergency specialty. So to summarize, emergencies not an individual game but more of team, a trained team with good support of both good services and good specialty departments, especially ICU and other specialty department. And with as a teamwork, we can definitely save more and more patients and give them those domains which was mentioned by the Institute of Medicine, that is safe, effective, patient-centered, timely, and equitable care. So let's together make more safe care to the patients coming to ER. Thank you. So we are open for questions or any comments from the faculty members.
Congratulations for the
Thank you, sir.
fantastic presentation and also data I have seen. There are two things, my suggestions here, when you are taking the take-home message, and before that, the problem statement. Suppose you are showing that the 1.4 billion, we need the 1.4 lakh doctors. Yeah. What is your suggestions? And one thing we missed, the how you will take care of the help of technology. Like pre-emergency or pre-hospital emergency care, only paramedics will not suffice to take the care. That is, you have to elaborate more or think. Like recently, they have given PS, like Prime Minister Scientific Advisory Committee, they have started one trial how they will help the emergency patients before reaching hospitals. And with this, I have given that things, they will start the pilot study here. Maybe 1 or 2 more weeks before they will come and see. That is the one thing. Otherwise, overall, I think this is a very good thing, and in the right direction we are moving. And two things, networking of the hospitals. We are having any systems. We have made that which hospitals we can know that where we can send the patients, because we cannot accommodate. And triage should be very efficient. And another thing I was thinking, like the take-home message from Central Institute Body meeting this time, Dr. Kuldeep was there also. They are telling that suppose like this investigation services, which is not like dependent, we will dependent on the faculties, it is taking long time. Should we outsource it for the immediate results? That the people are there to take care. Whether this immediate investigations will help you in triage, or what is the time now at this moment we are having, all this evaluation we need. Any more things you can?
Yes, sir, the important comment, sir. Thank you. So really, we have a huge challenge because of the patient number, burden of patient we have, and the all hospitals are overburdened, and the kind of patient number of the cardiovascular disease and other injuries are increasing. So definitely, we need some disruptive thoughts and innovation how we can handle those kind of emergencies. So definitely, pre-hospital care should be improved. We should more strengthen our pre-hospital care, PSC and CSCs to handle such care at their level. And AIMS as a resource center should take a lead to train those centers like by hub and spoke model, and with telemedicine or tele ICUs or and with tele pre-hospital care we can definitely provide the care before patient reaches to us.
The most important thing what we are facing here, or any aims like new aims, this is the coordination among all departments, and typically all the disease management now going on the multi-professional approach. And typically this is the department where actually multi-professional involvement is required. So how much it is here, that is the one thing inside study, like when we are discussing all this thing, we have simultaneously we are having our own data. How much we are efficiently managing our own people, our own department, our own existing services, that thing we should know also. How we will, for the administration, for everyone, we should know that is the data we are getting, how efficiently we will manage one part. Second thing, how we can do the future. And existing system, how we are taking care. Three things are more things we need more robust and ethical, authentic data, then we can move in the right direction. See, absolutely we cannot take care of everything. 1.4 billion we can do. But we have to start, we have to innovate many things. Like the most important thing, we are having the collaboration with IIT. This any technological development we can take the help, or where we can innovate anything to take care. That way we think. Not like endpoint we are not taking care, so many patients or these things we will sit down and think. But simultaneously where we are lacking, we have to more efficiently focus. That's my point.
So I agree with you that that is what I was trying to ask you, that there are only 10 or 11 faculty in the emergency medicine, and the residents are also, you are saying 12, but they are non-academic JR, non-academic SRs, so other, and there's contribution of the other department also. So that data also should be highlighted. That is the faculty of the emergency medicine, how much time they are devoting to their parent department, and how much many the parent department's faculties are helping the emergency medicine department. And second thing is about the, you say that the disruptive technology, and I agree with sir also that now we have IT, Jodhpur, and we had a organ day celebrated there. So it comes to our mind that how the technology can be used. Now we have a drone technology which can reduce the time taken from the periphery to the hospitals in the busy streets. Second is that we have now trains also available, Vande Bharat, indigenously developed, and we can create an ambulance from here to other stations also. So that will be facilitating, and it is like connected with the 5G. So how the technology can also be used, that can be disruptive innovation should be used. And thirdly, as we are preparing for the next step, is the strengthening and capacity building and awareness. That is, when we say about the lack of services in the ambulance, the shortage is ours. That is, we have to find out what are the shortages are there, and under whom control these ambulances which are standing outside in the emergency are there. So we can talk those people about how to strengthen the services. And then we can have a very good system of communicating with the other department. I think, sir, hum log at AIMS Jodhpur, we have a good collaboration with MDM. So most of the patients we are referring, and they take through the ambulance, our institute, to these hospitals. So, and we just talk to them, communicate with them, so that they take the patients till the patient is stabilized here.
The other things where we can use our technology and we have to innovate something that we can strengthen our services. Because otherwise, for this small number of faculties and staffs, definitely overburden and burnout for everyone. But we have to, because this time is coming, the emergency trauma and emergency is already recognized as specialized department. The new curriculum, everything is separately designed. Then we have to innovate, we have to plan accordingly. Not like that one mindset, cannot do it. So we can do a lot of things. That is the one point. That's why I am telling each point, so whatever telling, 1, 2, 3, we have to start the writing our own drawbacks. Drawbacks means that is data,
Definitely.
like the capacity building, where we are lacking, where the multi-professional approach, how we are getting the help from other departments, that's percentage by this, where we are lacking. Then we have to address all this. So many things we can address.
Even we have some inbuilt courses in our MBS curriculum. That is a course on management in the 7th semester when they are posted in the casualty and the community. So they can this part can also be built in our emergency, because management principles are very important. And we have now coming with the family medicine also, MD in family medicine from January. So that also will increase the load on the emergency, and how we can evolve this into a specialty.
Definitely, sir. We can utilize them to strengthen our service. Definitely.
Thank you for the excellent work. Two suggestions, mostly things might be happening, at least I don't know. As sir mentioned, the burnout, because it's one of the most difficult area of any hospital. So hope there is some briefing programs, or basically it's called debriefing, because some or other things have happened, went very difficult, but now things are relatively okay. So the team is talking with easy mode, because a lot of stress can be shared and relaxed in various setups if it is happening. And two, as I know here, Jha sir has a lot of interest in the road safety, driving mode, and some other team, Dr. Neeti and other road pre-hospital care. This is actually hospital thing. So hope some good coordination among those all teams, and then definitely the better outcome, the better product can come. Thank you.
Definitely, it's a teamwork. Individual person can't manage all things. So we require support from community medicine, other various departments to improve those things. And as I mentioned rightly, sir, burnout are very common, and we require more frequent counselings or more interaction with of our residents and other members for psychiatric department to resolve those issues maybe.
Dr. Bharat, for highlighting various important points and the challenges. As Dr. Naresh rightly pointed out, we have been working in regarding pre-hospital trauma care for some time, and we have got some insights. So one of the insight is that at PSC CSC, doctors, they are not willing to provide care to emergency and trauma patients concerning medico-legals because of the medico-legal concerns. So any insight you have that how these things can be taken up, especially while training our undergraduates? Because whenever they are posted in peripheral areas, the only thing they feel is that refer the patient as soon as possible, because it has all those factors of inciting violence or getting into complexities. So any take you have on that?
So actually, these all started. If we can see, understand this, there is some lacuna in the system as well, because the increased burden, lack of facilities, and ultimately, if something goes wrong, every finger goes towards the doctors. So the who doctors working at peripheries without much facilities, and they are at the point of care if something goes wrong. So we have to give them more confidence and give a system to support. A social plus legal system should be there, so that even if something goes wrong and they are taking timely care and managing the best care for the patient, so they should have some security or something like that, so they can get more confidence in managing those patients. Really, that is issue. Even private clinics, small private clinics, PHCs, they refuse patients and directly refer to the other hospital before giving any care because they're scared of systems, legal issues, and the overcrowded patients and angry patients and relatives. So these issues are very common actually. Thank you. Thank you.